Well, hello guys. My name is Caetano Marquezini. I'm a bariatric surgery and been doing bariatric surgery for the last 27 years. I live in Curitiba, Brazil, and for me it's an honor to be invited to be part of this faculty talking about NAFLD and fibrotic liver disease. These are my disclosures. I guarantee none of them will influence on my lecture now. Well, first things first, I've been doing surgery like this with this 45 angle position on the back of the patient. And this angle position modifies consistently the fat and visceral arrangement inside the abdomen and improves the visual angle of the optics and shortens the distance between the trocar entrance and the camera and the hiatus. This is very important because when we do surgery in these very fat, very large patients with a very large liver, when you do this angulation, it really helps a lot. Another thing important are the liver retractors. You have to choose properly the liver retractor. Usually conventional liver retractors can damage the liver of these patients with NAFLD or cirrhotic livers. So you have to take really care of this. There's a lot of public publications, a lot of papers talking about proposals. I really encourage fellow surgeons to take a look at these papers and choose properly the better and the best liver retractor they can find for the situation they will find during the surgery. What we know about these patients that go under surgery, the prevalence of NAFLD is 62.5%. 1/3 of them already have fibrosis. 9 to 20% will progress to cirrhosis. And cirrhosis will be diagnosed incidentally in 4% of surgeries. The surgery impacts on NAFLD in 88% of improvement and leads to 30% of improvement in fibrosis. So it's a good procedure. Well, the gold standard diagnosis is liver biopsy, which is important to calculate NAFLD activity score, and this is important for the future of the patient. And interestingly, there was no statistical difference in the improvements after sleeve gastrectomy and Roux-en-Y gastric bypass, although we know surgeons prefer doing sleeve gastrectomy for a lot of reasons. And one of the reasons is that you will lose the access for the biliary tract of these patients. The Roux-en-Y gastric bypass will make a very important modification of the anatomy, and these patients may need in the future liver transplantation and a lot of other reasons, but we know that surgeons really do prefer doing sleeve gastrectomies. Well, the biggest hindrance of preoperative counseling of these patients is about the risks of the surgery, and in the majority of cases, the risk of finding cirrhosis during the surgery. So routine intraoperative liver biopsy should be offered to these patients and talk to them about the risks of the procedure. We know it's not a harmless procedure, so you should talk to your patient about it. Liver stiffness measurement can reliably predict the presence of advanced fibrosis preoperatively with a sensitivity of 80% and specificity of 85.5%. Early preoperative liver decompensation may happen in these patients in 7% of cases, which should be managed conservatively. Roux-en-Y gastric bypass should not be a contraindication, being reserved for situations where sleeve gastrectomy is not possible, as Barrett esophagus or severe GERD. Well, in cirrhotic patients, portal hypertension is a relative contraindication for metabolic surgery, and it will ameliorate the comorbidities as type 2 diabetes, hypertension, dislipidemia, but it will probably not show any improvement in cirrhotic liver fibrosis. Mortality in patients with compensated disease is 0.9%, 3 times more than conventional surgery, and 17% in patients with decompensated cirrhosis. There's a limited data on outcomes on bariatric surgery in cirrhotic patients, and in case with advanced liver disease and severe portal hypertension, TIPS procedures should be considered prior to the surgery. Finally, patients with ultrasound-proven esteatose and ALT level above 53 should undergo intraoperative liver biopsy because of the high probability of NASH. Well, these were my considerations, and I hope to be soon with you to discuss my statements. See you soon. Bye-bye.